Dr. Atul Prasad, sir, for the talk, Logical Progression from Antiplatelets to Anticoagulants in Ischemic Stroke. The chairpersons are Dr. Bhavna Sharma, ma'am, and Dr. Vipin Ola, sir. Dr. Bhavna Sharma, ma'am, she is a senior professor and head Department of Neurology, SMS Medical College and Hospital, Jaipur. Dr. Vipin Ola, senior consultant, Neurology, Apex Hospital, Jaipur. I would invite Dr. Surendra Khoshia to present a bouquet to the speaker and chairperson.
Good morning, ladies and gentlemen. At the outset, our sincere thanks to Dr. Suresh Gupta for inviting us here as chairpersons. For the next 35 minutes, we are going to listen to Dr. Atul Prasad, who heads the Department of Neurology at BLK Super Specialty Hospital, New Delhi. He has an experience of around 30 years and his major area of interest are headache and stroke. He has major achievements like 12 chapters in books and more than 50 publications in various national and international publications. May I have the pleasure of inviting Dr. Atul Prasad and asking him to deliver the lecture.
Good afternoon, everyone, and I hope I'm audible. Always difficult to talk post tea. People are still restless, but I'll try. What I'll do in the next half an hour, 35 minutes, is to give you a peek into my mind how I manage patients with anticoagulation. Now, for those of you who have been there in the morning, and I presume all of you have been there in the morning, you are familiar with this slide. You're familiar with the block vessel, and you have learned from various speakers how to thrombolize, how to open up the blood vessel. So a scenario where a patient comes with a blocked vessel in the brain and you have opened it. The obvious question which comes is, what next? What next should we do? We cannot leave them alone. Why can't we leave them alone? Because if we leave them alone, this is what will happen. In the first 3 months, 18% will have a recurrent stroke. Within the next 5 years, nearly a quarter of them, 1 out of 4 patients will have a recurrent stroke. And it's not just a stroke which we worry about, not just a stroke which we worry about, they're also more prone for other vascular diseases. There's a 5 to 7 times more risk of a heart attack, peripheral vascular disease. So obviously, we need to have some long-term strategies for managing the patient following an acute stroke. And obviously, the first step is you deal with the risk factors, and I won't talk about them, that's another talk, but you will go through all the checklists, diabetes, hypertension, smoking, etc., and you're going to take care of that. But at some stage, or practically for all the patients, you will take a decision to put them on thrombolytics, antithrombotics. And when you put them on these blood thinners, our options are to target either the platelet system or the RBC system. The platelets have already been covered by Dr. Padma, and we know that we have an option of aspirin and other agents. And the anticoagulation is what I'll be talking about. And the options are to use the vitamin K antagonist and to use the other non-vitamin K antagonist. Okay, so my talk will be mainly upon the left part of the slide. Now, for a long time, this has been my favorite drug, and it's a good drug. And you have heard a lot about it from Dr. Padma. It's a very good drug. And it helps. It reduces the risk of stroke by about 15 to 20%. Or another way of looking at it is that number needed to treat. We need to treat 36 patients for 2 years to prevent one vascular event. 36 patients for 2 years. That means a wonderful drug, a superb drug, but it's still suboptimal. So if aspirin is suboptimal, what next? The options are that you use stronger medicines, or you use medicines in combination, and Dr. Padma has covered that, or we start use anticoagulation. And this is what I'm going to talk about, anticoagulation, not antiplatelet. Antiplatelets have been covered. Now, if you see the anticoagulation versus the antiplatelets aspirin and anticoagulation have been there for a long time. They have been there. Warfarin has been there since 1957. However, we have never been sure. We have never been sure whether warfarin is better than aspirin, or a combination of warfarin plus aspirin is good or better than aspirin alone. The first study which looked at it was a war study, and slide is not moving forward. But it's a war study. They looked at 2,206 patients, and there were two arms: the warfarin arm and the aspirin arm. They were followed up for 2 years. What is more interesting is they excluded patients with with a cardiac source of embolism or a high-grade carotid stenosis. And the most important thing, the INR used, or the targeted INR was 1.4 to 2.8. So remember this slide, remember the last line, the INR used was 1.4 to 2.8. This study was designed to show that warfarin is superior. It did not show. It failed to show. This graph shows that it showed that they were nearly same, but since the primary goal, primary endpoint was whether warfarin was better, this study, or the first study, the war study, is taken as a negative study, a study which did not show the superiority of warfarin over aspirin. So why was it not effective? Why is it not effective? Is it not effective because the amount of the target INR was too low, 1.4 to 2.8? And then came the second study, that is a spirit study. Here the target INR was between 3 to 4.5, 3 to 4.5. And do you know what they did? What happened to the study? The study was stopped. The study was stopped because there was a very high risk of hemorrhage. So 1.4 to 2.8 is not effective. Target of 3 to 4.5 is too dangerous. And then came the third study, the spirit study, and Dr. Padma did talk a little bit about it. There were three arms, and I'm not talking about the combination arm. I'm talking about the arm where the warfarin was used in a dose of to target an INR of 2 to 3. So a study which showed that whether the INR of 2.2 to 3 is better or not, and the conclusion was that we have got the correct dose now. We have got the dose of INR target INR of 2 to 3. However, warfarin is not superior to aspirin in patients of stroke who do not have a critical carotid stenosis or do not have a cardiac source of embolism. So we have got one part of warfarin right, that is the target INR, but it did not seem to be working. So where were we going wrong? Is it possible that we were not choosing our patients properly? And then are there subgroup of patients who would benefit from anticoagulation? That means the target INR is right, but still patients are not doing better. What's the reason? And there were 4 other studies, hypothesis-driven studies under the WALS umbrella. One was the antiphospholipid antibodies in stroke study, the APAS, patent foramen ovarian hypertrophic stroke, the genes in study stroke, and the hemostasis system activation study. That means a subgroup of patients, they have a specific problem. They have a specific problem leading to a stroke. That means now we're looking at the mechanism of stroke, and not just ischemic stroke with a target INR of 2 to 3. So there's a difference. All the studies were negative. All the study was negative. So is warfarin totally useless? We have a target INR which we know works, but sub-studies or looking at the mechanism of stroke, we still don't seem to have found the population of patients with a particular mechanism of stroke who will benefit from warfarin. So people still went on looking, and there were more studies, and they looked at symptomatic intracranial stenosis, high degree of intracranial stenosis with a warfarin. You need more stronger blood thinners with the warfarin is better in this group of patients or not. Number 2, patients with atrial fibrillation. Number 3, patients with aortic arch syndrome, the ARCH study. And the last for the WASS study, we looked at warfarin in patients with very low ejection fraction. So again, the hunt continues to look for a population who will benefit from anticoagulation. We won't talk about the first one, won't talk about the third one. These are negative studies. So intracranial stenosis and aortic arch do not really benefit from warfarin. Now, these other 2 groups which are left, That is the one with atrial fibrillation and with low ejection fraction. I'll talk a little bit more about them because these are the first positive studies which came using anticoagulation as a modality of prevention secondary stroke. Talk about warfare first, 2,000 patients, 176 sites, and they took patients with low ejection fraction of about 35%. So patients who are in normal sinus rhythm but low ejection fraction, whether these patients will benefit or not. Target INRs 2 to 3.5, one arm, second arm is aspirin. The conclusion was that if the person has a very low ejection fraction, they will benefit from anticoagulation. Very severe heart failure, patient with dilated cardiomyopathy, low ejection fraction, they will benefit from incidence of stroke. However, do not routinely use it. Do not routinely use it because there's a high risk of hemorrhage. So, if you're a neurologist and if you have a patient who comes with a stroke and low ejection fraction, you will put them on warfarin. You will put them on warfarin because he is at high risk. He's at high risk because he already had a stroke. If you're a cardiologist and if you just see a patient of low ejection fraction, but no stroke, maybe you may want to give, you may not want to give. You look at other risk factors. And the other risk factors I'll talk about now. Okay. So, definite indication in patients with severe cardiac failure, in patients with very low ejection fraction, with a stroke or who are at high risk for recurrent stroke. So, does not work in the brain, does not work in the aortic arch. I've talked about low ejection fraction. Let me talk about atrial fibrillation or the active trial. So we have a patient with atrial fibrillation, and in these patients, what is the role of anticoagulation? Now, in atrial fibrillation, there are two types. It can be valvular or non-valvular. Irrespective, because valvular or non-valvular, they have a very high risk of stroke. A very high risk of stroke. If they have valvular, there is 17 times more risk of stroke. Look at this. Of stroke, and this is irrespective whether you're having paroxysmal atrial fibrillation or whether you're having sustained atrial fibrillation. In fact, it's safe to say the worst thing about atrial fibrillation is not AF itself, but the risk of stroke. I'm not sure the cardiologist will agree with this or not, but as a neurologist, if a patient has atrial fibrillation, do rate control, good enough. May or may not go for rhythm control. Rate control is good enough, but what we worry about is stroke. And this stroke is irrespective whether it's sustained atrial fibrillation or whether it's paroxysmal atrial fibrillation. The patient is at low risk, moderate risk, or high risk. And how do we decide the risk, low, moderate, or high? We use a scale. Known as a CHAS2 vascular scale. And if the scale is more than 2, that means these patients are at a very, very high risk. Now that I've shown you the CHAS2 vascular, let me show you one more scoring criteria, and this is Hasbled. If you forget this whole talk, do not forget this Hasbled scale. See, if a patient is having, if you decide in your mind the patient requires anticoagulation, you will anticoagulate. Now, what we worry about most when we anticoagulate a patient is the risk of bleeding. How do we decide the patient is at high risk of bleeding or not? We use a small scale known as the Hasbled score. And the higher the score, the more the chances of bleeding. And for the rest of my talk, whenever I talk about using anticoagulation, I'll keep referring to the Hasbled score to decide whether you want to use high doses of anticoagulation or low doses of anticoagulation or not use anticoagulation at all. So forget the whole talk. If you want to, you should not, of course, but remember the Hasbled score. So warfarin atrial fibrillation, when you have a patient, a patient with atrial fibrillation and stroke, there are 3 questions which you have. The first question is whether warfarin is better or aspirin is better. Second question is whether warfarin is better or aspirin plus clopidogrel, the combination is better. And third question is, if you're convinced that warfarin is better, whether warfarin plus aspirin will give a little bit more benefit. The answer to the first question is that warfarin is definitely better compared to aspirin for reduction of stroke. However, chances of bleeding is a little bit higher. Second question, whether warfarin is better or aspirin plus clopidogrel is better, the answer is a no-brainer. Warfarin is much better. Do not use a combination. You will land up with bleeding, and you will not get any further benefit. The third meta-analysis showed that if you're using warfarin, combination does not give you more benefit. So use warfarin, use anticoagulation only. Only do not go for combination of warfarin plus aspirin. Okay, so if you're convinced now, if you're convinced from the data that the warfarin is better, the matter is closed. By put all the patients on warfarin, try to maintain an INR of between 2 to 3, and the patient will do well. Now this slide shows you that patients for maintain this 34% will be maintained in the INR of 2 to 3. So as long as they're in this INR, they're doing well. They're doing well. If they go below this or they go to above this, they're not doing so well. If they go beyond it, there's a high risk of bleeding. If they go below this, it's just not effective. So this is very important. It makes sense to use warfarin. However, we should make sure that the INR in the target range, and not only is it there in the target range, it should continue to be in the target range over a period of time. This is known as TTR, time in thrombotic range, and it should be ideally be more than 60% for your warfarin to be effective. Even in a country, even in the big countries, it's difficult to maintain an INR in that range. In India, it's only about 49%. So you can maintain, if possible, INR between 2 to 3, and you should try to maintain it over a period of time in that range. If you do not do that, you may be harming your patients more. This solid black line indicates no warfarin. Obviously, if you continue to maintain the patient in this TTR, time in thrombotic range of more than 60%, you're benefiting the patient. But the moment it goes below this, you may be harming the patient. You may be harming the patient more than if you're not using warfarin. I don't know if this makes sense or not. The logic is like this, that if you give warfarin, and if you are maintaining it in the INR 2 to 3 over a period of time, the patient benefits. Now, if you're not able to maintain it in that range, that is less than 2 if you're maintaining it, or you're unable to keep it in that range, you may harm the patient. How do you harm the patient? You harm the patient because if you're unable to keep it in that range, it's better to just put them on aspirin. Aspirin is not as effective as warfarin, but aspirin is more effective than warfarin if warfarin is given in a subtherapeutic dose. So either you use the medicine properly or don't use it. So why do we have this problem of maintaining the INR between 2 to 3? That's because warfarin has just too much of difficulty using it because of drug-drug interactions with your food stuff. It takes time to build up. It takes time to wear off. There are too many issues. So what we need is a medicine or drugs which are as effective as warfarin and as safe as aspirin. I mean, obviously, you want drugs which are highly effective and do not cause side effects. And this is the roles of the novel oral anticoagulants which have come into the market. These act differently. They act here either direct thrombin inhibitors, that is dabigatran, or they are 10A inhibitors, which are the rest of the oral anticoagulations. These are a group of drugs. Which act at different mechanisms to vitamin K antagonists, and they help to maintain the anticoagulation. Various studies, I won't go through all of them, but all of them show that these novel oral anticoagulants, they work very well. They're more effective. As effective, definitely, but more effective. Everything is on the left side. This favors warfarin, this favors the study drug. So all the trials show that the novel oral anticoagulants, they work very well, and they're safe. Except for GI bleed, they're safer than good old warfarin. So now we have a group of drugs which are easy to give, which are easy to which work, and which are not so dangerous. I won't go through each and every novel oral anticoagulant. This is not meant for that. I'll tell you how I use it in my practice. So patients which are well controlled on warfarin, the guidelines say, go to the second one. Patients who are on, if patients are controlled on warfarin or acetrom and the TTR is high, there's no need to change to any drug. But if the patient is poorly controlled on the warfarin, or if you is controlled but the time in therapeutic range is low, you may consider putting the patient on a novel oral anticoagulant. The level of evidence is 2B. Now, if a patient has not had a stroke, you categorize him using a CHAS2 vascate, whether he is at high risk or not. And if they are at high risk, you will put them either on warfarin or you will put them on the novel oral on one of the NOACs. If the risk is low, you need to decide. You need to decide if the CHAS2 score is less than 2. You may consider using either a warfarin or a NOAC, depending on your expertise with either of them. And this flow chart shows you essentially the same thing. A CHAS score which is low, which is 0, you may not decide not to give him anything. If it's 1 or 2, you have to give. 1 you may or you may not, depends on you. As a neurologist, any patient with atrial fibrillation who comes to me would have had a stroke. Otherwise, they won't come to me. They'll go to a cardiologist. So if you see the CHAS2 score is 2 points for old history of stroke. So all patients of stroke who come to me with atrial fibrillation will require anticoagulation. NOACs in special situations, kidney disease, elderly. I'll go through each of them quickly. Now, this chart or this table, the point to concentrate only is the first row and the last row. First row tells us that the apixaban has the least excretion from the kidney. Dabigatran has the maximum elimination by the kidney. So obviously in kidney disease, you would want to use a drug. It has least elimination by the kidney, and Eliquis or apixaban is my go-to drug in patients with kidney disease. Those has to be adjusted, and you must remember these 3 things. Creatinine more than 1.5, 80 years weight less than 60 kilos, the dose has to be adjusted if any 2 out of these 3 are positive. It's a good formula to remember. Also because of the next slide, in the elderly, the same rule applies. Same rule here. So if the patient has an age more than 80 years, if the body weight is more less than 60 kilos, or creatinine is elevated, the drug of choice should be apixaban. If kidney functions are all right, you can use dabigatran. But the dose has to be reduced. And the dose reduced is given out 310 milligrams twice a day. Patients of valvular heart disease. This is the one which is talked about most. First definition of vascular heart disease in 2014, they said atrial fibrillation. The patient has non-valvular or valvular. Under valvular, there was rheumatic heart disease, prosthetic valve, mechanical or bioprosthetic, and mitral valve. They said that if patient has a valvular atrial fibrillation, do not use NOACs. The definition was changed. Rheumatic heart disease became moderate to severe rheumatic heart disease, and prosthetic mechanical valve remained. The other valves under no valvular disease went the mitral valve repair and the mechanical valve. So these 2, bioprosthetic valves and after mitral valve, is a gray area. A lot of cardiologists do not put the patient on anticoagulation after bioprosthetic valve, unless they've had a stroke. So this is a gray area. You may decide or you may not decide, but definitely in patients, it's not that all valvular disease do not require. If patient has aortic valve disease, you should not be you cannot use NOAC. It's not like that. Moderate to severe mitral valve is definite contraindication. A metallic prosthetic valve is definite contraindication. And this is what the guidelines also say. The last one, NOACs can be used. However, they're not recommended in patients with mechanical heart valve or moderate to severe. These are the 2 contraindications in valvular disease where NOACs cannot be used. You have to use warfarin. Acute coronary syndrome. So acute coronary syndrome, the recommendation is with or without PCA, patient would require 3 blood thinners, warfarin, NOAC or warfarin, along with the dual antiplatelets. The triple therapy is for approximately a period of 1 to 3 months, followed by dual antiplatelet therapy up to 1 year, followed by a single blood thinner. This is from the cardiologist, and you can go through it if it makes sense to you. But we are neurologists and we have a simpler brain. So look at this chart. First 1 month, all three. 1 month to 1 year, you need two. The NOAC, patient has atrial fibrillation, so NOAC plus clopidogrel, and after 1 year, only anticoagulation and no other things. Nothing else to be given. And if anybody wants the reference to that, there are two trials which came in 2019. One is the oral anticoagulation extend trial and the AFIRE trial, which both of them showed that beyond 1 year, if a patient does not have any ongoing vascular events, it's quite safe to use only oral anticoagulation. Patient with acute stroke. The patient is on NOAC, patient is on oral anticoagulation, and patient has a stroke. So depending on the type of stroke, if patient has a hemorrhagic stroke, it's bad luck for him. Nothing much which you can do. You can give fresh frozen plasma, you can give PCC. The prognosis is poor. If, however, patient has an ischemic stroke, it's very important to take a history of whether the patient has discontinued the NOAC. If NOACs have been discontinued more than 48 hours, you can thrombolize. If patient continues to take NOAC and has a stroke, then it's better not to thrombolize, better just to go for mechanical thrombectomy. There are strategies where you can reverse the effect of dabigatran with the reversal agents, but the safer thing is just to go for mechanical thrombectomy. What about patients with a recent history of stroke? Just to pause, just to step back, patients who are at high risk should be on anticoagulation. And if they are on anticoagulation, you're going to use a scale to decide whether they're going to be in anticoagulation. And if it's more than 2, they will require. If the patient has a recent stroke and is at high risk for another stroke, the danger is, of course, chances of bleeding, and you have to balance the risk of benefit versus the risk of bleeding. These are the risk factors for recurrent stroke, including the CHAS2 vascular score, and these are the chances for a bleed. I'll take a couple of minutes. And when to start the oral anticoagulation? Answer is that we still do not know. These are the guidelines, and even if you see as of 2020, the Canadian guidelines, they go on to say that we do not have enough data. We do not have enough data to say when to start. But last year, there was one trial, the timing trial, which said that you can use NOAC even as early as 5 to 10 days following a stroke. This is what most of us do, start the anticoagulation after 1 day, in a TIA, 3 days after a small stroke, and last stroke, 2 weeks. In patients of bleeding, microbleeding, where you are worried about restarting anticoagulation, again, the data is not very good. Most people, as Dr. Padma said, you would wait for a couple of months before you restart the patient of oral anticoagulation. There's one more option that is left atrial appendage closure. So if you're worried about a recurrent stroke, if the patient has a bleed and you cannot start anticoagulation, you can think of offering the patient left atrial appendage closure. So patient, when your patient has an atrial fibrillation and a carotid stenosis, do not go and put a stent for these patients. It's easier to just do a surgery for the patient because you want to avoid triple therapy and the chances of bleeding. So I finished my talk. Just a little bit of fun fact about oral anticoagulation. Warfarin came in 1954. In 2010, Pradaxa dabigatran came. It had a novel mechanism of action. It acted on thrombin inhibitors. So it was known as novel. The N in NOAC was used as a novel oral anticoagulation. Subsequently, it started being linked. It stands for non-vitamin K antagonist. Now, everything has a critic, and the critics always said that N is not a good thing to do. It's not a good thing to do because it doesn't capture everything, number one. Number two, it may mean no oral anticoagulation. And that's how the term came DOAC. is one of the direct oral anticoagulation, and that's the current term which is used for this neuro oral anticoagulation. Thank you for patient listening.
Thank you, sir, for summarizing all the major areas and summarizing all the trials, including the latest evidence and guidelines. And gradually, the paradigm shift is towards NOACs, as we have seen in all the slides. And the area of non-valvular AF is also, valvular AF is also shrinking. And now only bioprosthetic mechanical valves and severe mitral stenosis is considered as valvular AF. And even in carotid stenosis, we are using low dose NOACs and aspirin. So I think they are the future drugs. And thank you, sir, for covering comprehensively the major topics.
Thank you. Now I will request Dr. Bhavna Sharma ma'am and Dr. Bipin Ola sir to present a moment to Dr.